Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
This is Dr. Ted Rosen, editor-in-chief of the Dermatology Digest, bringing you another edition of Let's Get Lit. We're going to talk about recent literature, and I have some pretty interesting articles for this edition. Let's start by talking a bit about rosacea. In the September issue of the Journal of the European Academy of Dermatology and Venereology, there was a review of 16 studies encompassing 1,445 patients. And I think we already know this, but it was nice that this review confirmed it. If you can get it, low-dose isotretinoin, about 0.3 of a milligram per kilogram, is actually quite efficacious in reducing the severity of inflammatory papulopustular lesions and also erythema, interestingly enough, over about 4 to 5 months administration. There's one thing you should know, though, that in this review they found that once that treatment was done and patients looked good, in about 5 to 6 months, about a third of the patients did experience a bit of a relapse, but they're much easier to control having had isotretinoin with things topically, for example, that didn't work as well initially. That's the same thing that's true about acne. And another very interesting article in the September issue of the Journal of the American Academy of Dermatology, the JAD, a small Italian study found that mild to moderate inflammatory rhinophyma actually improved with 1% ivermectin cream applied twice daily. I know I have a hard time figuring out how topical ivermectin is going to help soft tissue hypertrophy, but they showed some pictures and they were, moderately impressive. So that ivermectin, though, did have to be applied twice a day. They compared that to ivermectin once a day and 0.75 metronidazole cream twice daily. And you really need the twice a day ivermectin. So think about using that for rhinophyma, not severe rhinophyma. It's not going to make gigantic noses disappear, but it may help, especially early in the course. There's always a lot of literature around on atopic dermatitis. There was an interesting article in the October issue of the Journal of Investigative Dermatology where they analyzed matched cohorts that received either dupilumab or tralokinumab or abrocitinib or upadacitinib. So comparing biologics to JAK inhibitors. They were primarily looking at the downside, and the downside they found was that outpatient infections within about 6 months of starting either kind of drug occurred in about 18% of JAK inhibitor recipients versus about 12% of biologic recipients. That's a difference. We should be aware of it, but if someone has already done biologics, that shouldn't impair you from using a JAK inhibitor, I think. And we all do know, and they found again, that there was a risk of new onset acne in the JAK inhibitor recipients. And this particular cohort analysis, it was 7%. They did see a small number of new onset acne in patients who received one of the biologic drugs. There was also an Italian single center, keep that in mind, retrospective study of atopic dermatitis of the hands. There's a movement now to call that chronic hand eczema, but if you call it atopic dermatitis, you can get certain medicines a little easier. But after 4 months of treatment in this particular Italian study, they noticed that dupilumab worked pretty darn well. In fact, almost 63% complete response rate. But I think the really important take-home point from this study was the longer you use dupilumab, the better the response rate became. So that at 1 year, the complete response rate was 76.5%. And after 3 years, the complete response rate was 85.6%. And I think we're finding that with a lot of these newer drugs, whether they're biologics or JAK inhibitors, that sometimes you just need to give it time. There was an extensive literature review of 30 studies over 1,000 patients with high-risk cutaneous squamous cell carcinoma in the August issue of Dermatology Surgery. And I really liked this article because it helped me. What do you do other than cut the thing out or have it removed with Mohs surgery for a squamous cell? How do you evaluate high-risk patients? And they pointed out that in these many studies with over 1,000 patients, the MRI is best for detecting perineural invasion. A CT scan is best for detecting bony invasion, and the ultimate scan, a PET scan, is the optimum method for finding lymph node metastases. So there may not be just one imaging that you need to do for high-risk cutaneous squamous cell carcinoma. It may be that you need a battery of imaging, and maybe you don't order that. Maybe you send it to the medical oncologist. But it did show that different imaging techniques are better at detecting what we need to know about that patient. And I would highly recommend just taking a quick look at that, although I've given you the summary as it is. In the September issue of the Journal of Hospital Infections, a comprehensive literature review and meta-analysis, including 14,000 patients, found no significant difference in superficial wound infections following surgery, regardless of what preoperative skin prep was done. They looked at chlorhexidine and povidone iodine. I think we tend now to consider povidone iodine perhaps a little more irritating, but in terms of infection, didn't make a difference. So if you like chlorhexidine, have at it. If you like povidone iodine, have at it. They work equally well. And then my last surgical article was in the February 2025 issue of Dermatology Surgery. They used the Trinex database. That's a very large US database, 106 million Americans. They looked at solid organ transplant recipients who were receiving anti-rejection medication. And they are more likely, as you might expect, than immunocompetent patients to experience adverse events following Mohs surgery. That included postoperative infection, which I think we all would understand. But it also included wound dehiscence and surgical site swelling. So it's not just infection. There are other things that can happen to solid organ transplant patients after Mohs surgery. They really need close postoperative follow-up. In the summer issue of Skin Research and Technology, there was an article that pointed out that type 1 diabetes, type 1, not type 2, was a significant risk factor for vitiligo, but the converse was not true. Individuals with vitiligo did not have an increased risk of hyperglycemia or elevated hemoglobin A1C levels. There was an interesting article in the May JAD, Journal of the American Academy of Dermatology, looking at crisaborole. I think we've all been a little disappointed in that drug, especially up front, tends to be a little irritating. But now there's been literature that's showing using it long term for atopic dermatitis, it may be a pretty darn good maintenance drug. Well, this particular phase 2A study, small, was an N of 65, but it showed that crisaborole ointment applied twice daily was actually quite effective for the management of stasis dermatitis after a month to a month and a half of use. It's pretty quick. So if you don't want to use steroids on stasis dermatitis, one other option appears to be crisaborole. We need a bigger study than 65 and long-term data, but it looked promising. And, I'm going to try it. There was an interesting prospective, so not retrospective, but prospective study done in India about treating oral lichen planus. And they found that the addition of oral acitretin on the order of 25 to 35 milligrams a day, so pretty reasonable dose, was much better than steroid alone. So you add the acitretin to, they use triamcinolone in treating oral lichen planus. And nearly twice as many of those treated with the combination achieved a 75% reduction in an objective measurement of oral lichen planus activity compared to just topical steroids alone. So if you have some bad oral lichen planus, you're using steroid in whatever formulation you prefer, think about adding some acitretin again, but a pretty good dose, 25 to 35 milligrams. What do you do with patients with varicose veins if you do sclerotherapy? I did for many, many years, and I was usually pretty pleased. But of course, I picked small vessels. But what do you do for patients with varicose veins that sclerotherapy just is not going to touch? Many of us then send them to vascular specialists. And there's a very interesting study in the August issue of British Journal of Surgery looking at 10 years of follow-up for patients who are sent from dermatology to vascular specialists to see what happened to them. And it turns out the message here is that endovascular laser ablation fares better than the traditional ligation and venous stripping. The recurrence rate is lower, and the incidence of leg pain post-procedure over 10 years is greatly reduced. So if you're going to refer to a vascular specialist for horrible varicose veins, find out if they use endovascular laser or they routinely do the old-time tie off and rip out stripping. Endovascular laser does better in the long, long run. I think we're all using oral minoxidil now for a variety of causes of alopecia. And there was a very instructive and I think important article in the November issue of the Journal of the American Academy of Dermatology, a retrospective review, 16 studies, about 2,400 patients. And they point out that low-dose oral minoxidil, which they defined as 5 milligrams a day or less, many of us cut off at 2.5 milligrams, but they allowed all the way up to 5 milligrams, does not reduce systolic blood pressure. But do keep this in mind, which I think is the important point of this particular article, that about 5% of patients treated with low-dose oral minoxidil have symptoms that sound like their blood pressure is lowered, even though objectively it's not. That includes lightheadedness and syncope in 1.8%, dizziness in 1.2%, tachycardia and palpitations in just under 1%. And low-dose oral minoxidil recipients do have an increased heart rate as if their blood pressure fell, but it's pretty modest, 2.67 beats per minute. So I don't think we need to worry too much in someone who doesn't have baseline orthostatic hypotension. But do keep in mind that a small percentage of patients will have symptoms. I do think you should warn them of that. Things like dizziness, lightheadedness, syncope, tachycardia, and palpitations. A really cool study published in the October issue of the Journal of Cosmetic Dermatology. The study was done in Saudi Arabia, and it looked at 1,200 gray-haired individuals. And about 50%, a little over 50% of them, turn gray before the age of 30. There are two important risk factors. One you could guess, right? It's a family history of premature graying, so that predisposes the next generation. But the other risk factor they found was smoking. So if you need a reason to try and get someone who shows up with a pack of Camels in their pocket, if they still make Camels, but some cigarettes, you know they're smokers, tell them that increases their risk of gray hair. I love my gray hair, but a lot of people don't like gray hair. How about hidradenitis? In the November issue of the Archives of Dermatologic Research, there was an interesting look at vitamin D and its relationship to hidradenitis. You know, there are lots of articles about vitamin D, vitamin D, vitamin D. So you got to take this with a bit of a grain of salt, but they did found that vitamin D deficiency was common in HS, that vitamin D deficiency correlated with more severe HS, but the really important point they found was that vitamin D supplementation improves clinical outcomes in hidradenitis, regardless of what your underlying therapeutic intervention is. So, I mean, it's pretty easy to get vitamin D levels, and it's good for the patient to know. And there are some things I really do believe relate to vitamin D deficiency. So in my new HS patients, I'm checking them for vitamin D. And if they're deficient, I'm putting them on vitamin D, you know, a couple thousand units a day. There was a longitudinal study of 1,332 pregnancies complicated by hidradenitis in the October issue of JAMA Dermatology. And it revealed that mothers pregnant with hidradenitis are at higher risk of hypertension, gestational diabetes, and a variety of other morbidities. In addition, and this is something I didn't know, their offspring are about 30% more likely to be born prematurely or to have congenital malformations. So if one of your patients, they like us, right? They ask us about all kinds of stuff. If one of your patients you've been taking care of for hidradenitis becomes pregnant, they might ask you, how's this pregnancy going to be affected by my hidradenitis? I think you need to tell them their pregnancy can be a little more complicated and there are some risks, prematurity, congenital malformation to the child. And they need to convey that, the patients need to convey that to their obstetrician gynecologist. In the November issue of Cutis, one of my all-time favorite articles pointed out that if you use a small dried pinto bean and you put a little pressure and tape it down over a verruca vulgaris overnight, like one day and then overnight, you put the pinto bean on during their office visit, they keep it on, take the occlusive tape off the next day. That often leads to ischemia and sloughing of the wart. They just did digital lesions 1 to 2 days after application. Talk about simple, safe, and cheap. That's about it. November issue of JAMA Dermatology, a huge French study, 18,000 patients, disclosed that you're at increased risk of developing plaque psoriasis if you eat a lot of ultra-processed foods. I live on ultra-processed foods, but then I don't really know what ultra processed foods are. I guess it's not raw vegetables and raw fruit, stuff like that. They gave the example of pizza and sugary sodas, my staple. So if you got someone with a strong family history of psoriasis, might be worth telling them to knock off the pizza and sugary drinks. And then last, in the September issue of the ACR Open Journal of Rheumatology, a very interesting, it's only a single center American retrospective study, but it covered 15 years, looking at herbal supplements on the course of connective tissue disease in 673 patients. First thing is, I think you'll find if you ask that a lot of people are taking herbal supplements, unsupervised, willy-nilly, random recommendations based on TikTok or their next door neighbor. This is particularly common among younger patients. In this particular study, these are connective tissue disease patients. So they're ill. 32%, a third of them were taking herbal supplements. Pretty amazing. And dermatomyositis does way worse. It can be exacerbated by a variety of herbal supplements, particularly elderberry and spirulina, which is a blue-green algae. I don't routinely ask my patients if they're taking supplements, but this article made me think about I should include that as a specific item in their intake because they don't think of it as drugs. We don't really think of it as a medication drug, but these supplements can have physiologic effects. And it turns out dermatomyositis patients are particularly susceptible to adverse events of herbal supplementation. So we ought to be asking that. Some of the lupus patients also were adversely affected, but it was more common among dermatomyositis patients. So I hope you've enjoyed this issue of Let's Get Lit as we've reviewed some recent literature, and we'll do another issue pretty soon. Thanks for listening. It's Dr. Ted Rosen, Editor-in-Chief of the Dermatology Digest.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.